from Croaky here, and I'm talking to Dr. Brian Owler, the former president of the AMA, and here at the ALP Health Summit. In what way were you here today? What were you representing yourself?
I was representing myself. I was asked to come and chair one of the sessions on hospitals and to contribute in terms of my knowledge of health policy from my days as AMA president before. So, look, I think the main message of today is one of engagement. I think there is a thirst amongst people in the health sector to ensure that there is good policy going forward, to have that sort of engagement, to have a vision of what the healthcare system should be like in not just 5 years but 20 years' time. That does take a lot of work, and it takes bringing people together to have these sorts of conversations. We're not going to solve all of the problems in a few hours, but at least it gets people talking together.
Did you get the sense that any of those intractable problems got a little bit clearer today? Could you see the way ahead?
Well, to solve the problem, you've got to know what the problem is. So you've got to define where the problems are, and that gives some focus towards health policy. I think there are a few themes that were coming through. Certainly people are fatigued in terms of major changes, and we want some predictability and certainty about what the future holds to allow people to build services based on a certain model. But I think there's also issues around our health system and some of its foundations. I mean, I prefer the foundations of our healthcare system in terms of universality and equity of access, the importance of both the public and the private hospital systems and the balance that goes between them, and the importance of a strong private health insurance system. But one of the things that we're seeing is, particularly in the hospital sector, a lack of access, particularly at that outpatients end, actually getting a consultation, getting an appointment for people that don't have private health insurance is often much more difficult. The wait times can be longer, and so there is a different standard, and I think that is impacting on people's health. So we need to recognise that we need to make sure that we get back to some sort of equity. It's not to say that private health insurance is bad and it's all their fault, but I think clearly there's been some rationing in terms of the outpatients departments and the ability to get appointments in a timely fashion, and then of course to get the subsequent treatment following those appointments.
How deeply did private health insurance get discussed in your sessions, or at least the ones you were there? Do you think there is any move to say, look, the system is just not working and it's eating up very valuable funds?
Well, it's eating up some funds, and then the private health insurance rebate is $6.2 billion. But even if you shifted that all into the public system, it wouldn't meet anywhere near the demand that there is in terms of the services for public hospitals that would then create.
It'd meet $6 billion worth though.
Yeah, but that's nowhere near the demand that it would need. So I think people need to, the notion, well, let's just scrap that and put it on, that would be a disastrous effect, because we need to ensure that, yes, private health insurance and private health is important because it does ease the burden on the public hospital system. If you had all those patients going back to the public hospital system, there are not the resources that are there to provide the services that need. We're already struggling through public hospitals to provide those resources. So I don't think we should blame private health insurance. I think we need to sort out affordability, the premium increases, particularly in a setting of low wage increases, and make sure that the value is, that the product has its value maintained. But I think we need to make sure that we're also funding our hospitals properly, not just in terms of elective surgery and emergency departments, but all the medical services that they provide as well, and of course the outpatient services. We had a lot of discussion about subacute services as well, and the issues around funding between both Commonwealth and states. Now, there's been discussion about blame game between the two, and some of the reform previously was about trying to end that blame game. But I think where people transition between parts of the system that are funded by one sector or one aspect of government, and then transition to another area which is funded by a different government, there are definitely cracks in the system, and that's where some of the access blocks and the inequities are created. So there's some of the things I think need to be dealt with in a longer term health policy.
And we talked about that before. You said that hospitals actually are about acute services, they're not about others, but they need to link into them. And we had a story up at Croker this week actually that was done by one of the physicians from a public hospital, and just that patients have nowhere to go, so public, hospitals end up being hotels, or more expensive than hotels is the point, and they're, so
this is not new, of course. This is the whole discussion that we had around the previous round of hospital reform, and it was identified that funding acute, subacute services, so particularly rehabilitation, aged care facilities, making sure that there was a place for people to go was really important. So we talked a bit about the access targets today for emergency departments and elective surgery. Those targets were only part of the picture. The bigger picture was about whole of hospital reform and about making sure that there was a way of transitioning people through hospitals, and that was also about creating access to subacute services at the other end. So it wasn't just access block, there's exit block as well. And so we need to deal with both ends of the system, the access into hospitals, but also the way that people egress from hospitals as well.
What are the biggest barriers to that, and is it vested interest?
No, it's not vested interest. I think one of the biggest barriers is in terms of who funds it. So we still have a disjointed system because of differences in who's responsible for doing the funding. And clearly there's some incentive to cost shift from one government to another, and that is driven by administration and management of health services. But also there's sometimes a lack of incentive to reform and design things better to actually improve services, because the more services you allow into your system, into your hospital, the more expensive it becomes. And so there is, I think, a degree of rationing that occurs at the front end through access block, and that's one of the problems that we've got to solve.
On the doctors' front, we hear a lot about the Medicare freeze, but in other ways, it's the fee-for-service model. Do you think it's a really big barrier to integration of services?
No, I don't think that's actually the issue. Fee-for-service doesn't have to do with access. I mean, I think if anything, it probably assists with access. One of the problems that we've got is the funding of services for outpatients to begin with. So in a setting outside of hospitals, yes, there's fee-for-service. We have some fee-for-service in hospitals, but outpatients clinics have actually shrunk over the last decade or so. I mean, they used to be quite a strong part of the hospital system, but what we've done is shrink those down, and I think that is part of the rationing that goes on. It's that, well, if you can't get an appointment to get on the waiting list for your elective surgery, it makes our waiting list look better. So I don't think it's a fee-for-service issue.
But in terms of primary care?
Well, in terms of primary care, I think the fee-for-service model has actually served this country very well. I mean, it's been very good. Now, I think there are models that probably do better for chronic disease, and in terms of the healthcare home and those sorts of models that provide bundle type care, I think those are things that we've got to trial and see if they actually deliver the outcomes that people say or advocate that they will. But until those sorts of trials are done, I think we have to be careful about saying this is the answer, because sometimes it doesn't necessarily translate to our health system.
What do you see as the biggest risk for health equity in Australia, looking across the whole system with your experience?
Well, I think we keep going down the same path, and we keep seeing the contribution of governments as a proportion start to shrink, and the contributions from the members of the public actually increasing. And that's certainly what the Medicare freeze is about. It's actually about shifting costs onto patients. And the more you do that, the more inequities you create, because people, particularly families, those with chronic disease, those in lower socioeconomic areas, find it more difficult not only to go and see a GP that bulk bills, but also to pay for their medicines, for their scripts, and to access pathology, diagnostic imaging, and all of the other services that you might need to actually provide someone care.
Thank you very much for your time.
It's a pleasure.